My disclosures, not too relevant. This is a pretty easy talk because what is the standard? It's BCG. Okay, in fact, it's been universally accepted all over the world in every guideline, and it's especially the only therapy you think of consistently for CIS. There have been decades of experience, multiple prospective trials, meta-analyses showing durable, greater than 5-year, 10-year, in fact, improvement in recurrence-free survival, high-grade recurrence-free survival, and progression-free survival, with one trial that was randomized against epirubicin actually showing a metastasis-free survival and overall survival advantage. But you've heard about the problem with BCG shortage, and that has resulted in the need for additional therapies. I'll just tell you our story. In 2019, we felt acutely the BCG shortage crisis. We've been using gem-docetaxel for BCG unresponsive disease. Our inflow of patients from the community that had no BCG increased threefold, and suddenly we had enough BCG to treat 5 patients a month, and we were getting 30 patients a month. And so we switched them all as first-line gem-docetaxel, and that's going to be some of the data I show you. It has been accepted as an emerging de facto standard of care in the shortage era, and the AUA and NCCN both refer to it as an alternative option. Unfortunately, I also refer to other agents such as gem, single-agent gem and mido, for which there is no data whatsoever. In fact, I'll challenge anyone to find any data on the use of gemcitabine single-agent against primary CIS. I could not find any. The data we have on mitomycin goes back two or three decades ago, and was somewhere in the 45 to 55% complete response rate. The data comparing gem-docetaxel and BCG has been retrospective, but in all the parameters we normally look at, including all the way up to cancer-specific survival, there's been really no difference. And there is an understood difference in toxicity in the sense that there's a threefold less dropout. There was one quality of life study that was conducted in India with 60 patients, 30 got BCG, 30 got gem-docetaxel, and the quality of life indicators showed a superior profile for gem-docetaxel. I will mention there's been one prospective trial now that Max Cates led as a prelude to the Bridge trial, where he had, I think, 27 patients or 25 patients receiving upfront gem-docetaxel. Most of them were TA high grade. There was 10 to 15% CIS and a smattering of T1 high grade, and had a remarkable 2-year high grade recurrence-free survival. So even a prospective manner, at least at the gem-docetaxel level, the data seems to be pretty solid. Okay, this is what the curves look like, and this is important because as new trials enter the space, they're going to have a high bar to deal with. In the case here of, here's our 172 patients we treated at Iowa with BCG using the exact same parameters, meaning they also got blue light cystoscopy, all the biopsies, the upper tract washes and everything at the first 3 months. And then we went on to give them maintenance therapy in the form of 3 additional courses of 3 each at reduced dose. And, you know, the results are good. In fact, this is the high-grade recurrence-free survival, which is probably the most relevant indicator, because if we get a low-grade recurrence, it's not going to change the ultimate trajectory and life expectancy of that patient. And in this case, it looked like the gem-docetaxel may have been a little bit better, all the way out to 3 years. The patient group was very comparable. There's been a subsequent trial done by Wake Forest, also retrospective, where they had 27 BCG patients compared to 53 gem-docetaxel, and essentially near identical results at 1 and 2 years for both in the high-grade NMIBC space. Survival outcomes here you can see comparing progression-free survival, cystectomy-free survival, cancer-specific and overall survival. There is no difference here. But again, the problem is we know that BCG goes out and basically tends to level off even after 5 years, stays flat. We don't know if the gem-docetaxel is starting, as it starts to creep down here, will cross it or it will level off itself. So there's a data gap with regard to the durability of this treatment. Some things that may be interesting, though, you might think, well, if these treatments are the same, are they interchangeable? We have some initial data that they might not be. That is, BCG and gem-docetaxel in this space may target different populations. And I'll show you this. This is the data that was presented at this year's SUO, and it was from the group VALAR that has provided a AI algorithm based on histopathology and digital imaging AI. In this group, they could take a group of high-grade patients and stratify those with a positive biomarker indicating a worse response to BCG in terms of high-grade recurrence-free survival, or a better response in the blue of BCG. Here's the gem-Doce showing that this biomarker does not appear to work for gem-Doce, suggesting there's a subset that behaves differently in terms of the mechanism of action than does BCG. I'll show you one other thing that was a surprise. We took all of our patients, the same group of patients that got gem-Doce for BCG, and we looked, and one of my fellows wanted to look at the neutrophil lymphocyte ratio. I was very skeptical. I said, sure, go ahead and do what you want. And it turns out that an NLR that's high here, indicating a higher amount of neutrophils versus lymphocytes above a ratio of 3 portends a worse prognosis for the gem-Doce patients, whereas those below actually have a better prognosis. Quite a surprise. You don't think of gem-Doce as having any immune effect, but there are some in vitro studies showing that docetaxel, for instance, differentially inhibits Treg function. So perhaps there is something there. My point being is that we might need to use some type of biomarkers. This last one here has not been validated. The one above has been validated with large data sets. But it may be that when we get new therapies, there will be a way, hopefully, to shunt a patient that's going to do well with BCG into the BCG arm, a patient that's going to do better with gem-Doce into that arm, and a patient that maybe do poor for either. For instance, NLR also predicts poor BCG response, is to shunt them to something else. And what's available? Yes?
Sorry, before you go on,
yeah.
Can I just ask you a question?
Yeah.
So with Valor's validation
Yes.
study, so basically it doesn't predict for gem-Doce, but it predicts for BCG.
Exactly.
So I'm surprised why not flip the graphs there and just show the difference in the BCG and no difference in the...
Yeah,
you know
so
what I
this
mean?
is
Just
the
like
biomarker absent showing that the BCG performs well as gem-Doce. There's no statistical difference here. But when the biomarker is present, the BCG does worse, but the gem-Doce is similar.
Yeah, I'm just saying put gem-Doce in the same graph and BCG in the other graph and show the differences between the two.
Okay, sure. Okay, just stylistically, sure. But you get the point. Okay, cool. So what are the new agents? You've heard of this in part. I'll give you a little bit more detail. SWOG 1602, which is the PRIME trial, is a large trial that has accrued 1,000 patients so far. I talked to Dr. Swastik about this, Rob, and he's expecting the first readout not to be until 2026. Everything's accrued, but they're waiting for the number of events to reach the threshold that their statisticians are satisfied that it's going to give them a statistically statistically valid result. There apparently have been less events than they had originally proposed. I showed you before for the BCG, we're actually doing better these days than we used to. It used to be about 60%, now we're up to 70-75% for BCG. There is Canada does not have a BCG shortage because they have successfully been able to import the Russian strain that is used routinely in India. It's called, and the group that produces that is called Verity. They have proposed a phase 3 trial randomizing the Verity BCG to the Oncotype BCG. It's a phase 3 trial, has not yet started recruiting, but it is envisioned to have about 540 patients for that trial. The next, you've heard of the Bridge trial, which has been extremely successful in its acquisition of patients. I think they're hoping to get 870. I think they're above 500 already. They're accruing patients at the rate of about 50 patients per month. So we're probably going to see that readout within the next 2 years. Keynote 676 started a few years ago, and it's the Pembro plus BCG versus BCG alone in 3 different groups: the BCG unresponsive group, and persistent, recurrent, or BCG naive. So that one's going to have about, let's see, almost 1,400 patients in it. So big trial coming forth on that. TAR-200 plus citralumab or TAR-200 alone versus BCG. I think they might have dropped the TAR plus citralumab for this. Is that the case, Sia? BCG naive, right.
It was,
Yeah. They dropped that. Originally, that was set for 1,135 patients. There is a BCG plus N803 trial that is currently recruiting. It's expected to have close to 600 patients. And then there is a smaller trial of actually a large trial of BCG plus another IO called sathanlimab, and that's expecting to recruit about 1,100 patients. That's from Pfizer, and that's active but not yet recruiting patients. So we're going to see a lot of activity in this space. Obviously, some of the concerns is, when you're up against a BCG with a high bar, is there going to be enough BCG to run the trials? And B, is there going to be enough patients to meet a 10 to 15% difference? And C, is the cost going to be manageable or it makes sense to use this in the upfront center, especially as there are secondary agents available to rescue failures. So it will be an interesting time to see how many of these trials continue to plan on this accrual and whether or not they come to fruition. Okay.
I have a question about, I actually presented the trial in progress for the Keynote 057 cohort C for BCG refractory patients with the
EG70? No, which
it's
one?
with the LAG-3 and the TIGIT. But talking to Merck, I think they've shut down the program actually, ironically, and because they believe the systemic therapy is not really going to pan out in this space. So I was wondering what your thoughts are. Are these IO plus BCG trials, are they really going to move the needle, you think? Or?
Right. Well, there's two things. First, you're going to deal with the immune adverse events that are serious in about 10 to 15% of patients. And is that appropriate for a group who are beginning their journey with high-risk disease, but unlikely to progress in the early period of time? So that's one question. And the second is the IO going to be enough to push the curves up enough to show statistical significance? If it's not better than equivalence, there's no reason to use it, right? So you have to have a superiority trial as opposed to non-inferiority. So we'll see. I'm skeptical.
These trials are so, the numbers are so high. This is why the trials have such high N numbers and surprisingly have accrued quite well. CREST, the TAR-200 versus BCG, all of them are over 1,000 patients.
Right.
Fully accrued, we'll see. But like Mike said, the therapeutic value of going from 80%, I mean, you showed with gem-docetaxel BCG 3-year, we have 80% versus 76%, RFS in that. Are we going to improve it? How much delta are we going to get with the additional therapy vis-a-vis the systemic toxicities, which are well known and have been shown? Yeah. But
cost.
Right.
Not just efficacy, but cost.
And cost, of course.
So I have a
the
question.
sathanlimab is the side effects are obviously going to be
And that's going to be subcutaneous, I believe.
but
though,
it's
right?
a subcutaneous. So from a ease of, from a urologist perspective, if you go from 80% to 90% in 3 years, for instance, with an additional sub-Q injection, but you're going to still have the same immune-related complications.
Exactly.
So you have to be careful with that. But
It raises
It
an
may have
interesting
been,
question.
The question is, should you have gone to a BCG failure times 1 model where the relative improvement from a second course of BCG is reduced by about 50%? That would have given you a higher event rate to use smaller number of patients to also test the hypothesis whether this immune adjuvant would improve upon a group that has already failed partly with BCG.
We know that Eugene Pete Zak had presented our memorial data showing that by just adding gemcitabine to that second course of BCG, that perhaps you may really augment that response to the second course as well. But I wanted to just ask the medical oncology folks, how does this change the subsequent paradigm? So let's say you treat these high-risk patients. If these studies are positive and they get a checkpoint way early in their exposure, they fail and they progress, are they eligible for EV Pembro if they've already seen the checkpoint inhibitor previously?
That's
Unknown. I mean, I think that if you treat EV Pembro as a synergistic combination, one drug, I certainly think it's reasonable to do that. I don't think you're being hurt by giving pembrolizumab in that situation, but we really don't know what the contribution of Pembro is going to be.
I think, you know, and I had two comments. First of all, Merck 676 is dealing with a BCG exposed, so we will have some data about patients post-induction and comparing further BCG to BCG plus Pembro. There are some other studies in the BCG exposed. I think this is also, again, coming back to the biomarkers, you know, if you look at, you know, the Valor biomarker, which is just a histologic AI, if you identify the 10%, 15% patients who have much higher likelihood of not responding to BCG, then maybe looking at more aggressive or different therapy would make sense. So it's hard to imagine that every patient who's BCG naive is going to be on a checkpoint combination with BCG, but maybe 10%, it makes sense, right? I think we need to validate that, obviously, and we don't know if the patients aren't going to respond to BCG are also less likely to respond to BCG plus a checkpoint. So several steps here.
So this is where we need more long-term data and the impact of subsequent trials. I think one trial that would help us clarify whether there is any role for additional immunotherapy, and also this question of whether there is synergy with EV Pembro versus it being more additive, because there has been some thought it's additive rather than synergistic. It'd be interesting to take patients who are that post-neoadjuvant or post-IO and give them EV Pembro and just see what's the response rate. If it's 40%, well, that recapitulates more of what we've seen in the second-line treatment setting, which is post-IO, which argue many patients had had immunotherapy right before their EV and had some on board through the beginning of their EV on trials. So, you know, again, trying to tease out this data, maybe determining some real-life data of what's happening in these patients will try to give us some hints about the role of additional immunotherapy or not.
Yeah.
Mike, one other quick question.
Yeah.
So as the father of Doce, right?
Yeah, it's my baby.
That's your baby. And I remember as this baby was born, we had a conversation about how you picked the regimen, and they were non-overlapping toxicities.
Yeah.
And we also talked about why instead of using the full dose of gemcitabine, 2 grams, you went to 1, not 70 grams of mitomycin, you went to half. Was that you half the dose to try and minimize?
Yeah, we repeated the Delbagny study of twice a week at higher concentration, and we did have a lot more irritated bladder symptoms. And then there came another point where I increased it back to 2 grams in 50 cc's. And again, my patients just started to complain, and they hadn't been complaining at all. So even though we were alkalinizing the urine and everything else, so I'm convinced that there is a irritative component that's dose associated with gemcitabine.
So I guess my point is that there probably is some room to consider dose escalating to see if you could even improve upon.
Let me tell you, there's even more. Anecdotally, we have retreated patients that haven't had a complete response, who have relapsed with a small TA high-grade lesion, and it looks like about half of them are responding to a second cycle of Doce. We haven't offered to people that obviously had no improvement or progressed clinically on therapy, more tumors, and so forth. But there's a possibility also that you can do a second cycle. We haven't done the complete response any time, which is, you can criticize some of the most recent work in the BCG unresponsive space.
Okay,
Yeah.
excellent. Thank you so much.